So let's move on to this year's ASCO in 2018, and we've had some interesting data that's emerged in the EGFR space. We're going to learn more about this in the coming days. We've got a dacomitinib trial. We have erlotinib plus bevacizumab. And then importantly, we have looking at the role of immunotherapy in EGFR mutant lung cancer. So Lou, do you want to talk about the DACO trial that will, I think, be presented tomorrow? Yeah.
So yes, dacomitinib trial, another name of the trial is ARCHER, was a randomized clinical trial for patients with newly diagnosed stage 4 non-small cell lung cancer with EGFR sensitizing mutation. It randomized patients to dacomitinib versus gefitinib, and we just spent half an hour talking about the fact that gefitinib is no longer standard of care in any of our hands. So to put this trial in perspective, technically the comparison arm is not the arm that we use. But I think what's interesting about the study that this is the first study that ever showed improvement in survival when you compare two different TKIs, with an exception of the combined analysis of LUX-Lung3 and LUX-Lung6, which we're not going to talk about today. So the overall survival in dacomitinib arm was 34 months, and in gefitinib arm is 26.8 months. So I think, to me, my perspective on the study, I think it gives us maybe a hint that maybe osimertinib trial overall survival could be positive. That's what I take away from that study, because when you look at the hazard ratios, so the hazard ratio for the dacomitinib trial is 0.76. The hazard ratio in OSI study, FLAURA study, which is osimertinib versus erlotinib, the data is not mature, but hazard ratio is 0.67. So I think it is very possible that this is a preview of what we're going to see from the FLAURA study. Doesn't change my practice. My first choice for EGFR mutant patients still osimertinib, but I think it gives me some hope that osimertinib overall survival data will be positive.
And it's notable in that dacomitinib study too, the rates of toxicity were pretty significant with that second generation EGFR inhibitor. So I think that also plays into decision making about the first line options.
And then the other thing I'd also note is that unlike osimertinib, where untreated brain metastases were allowed, for dacomitinib it was not, because it seems to have less blood-brain barrier penetration.
And then lastly, if you look at the FLAURA publication, the survival curves do actually separate.
Yeah.
And if you didn't look closely, the p-value was less than 0.05, except for that number of events, you needed a much lower p-value to reach significance. So again, encouraging data that we will see a difference in survival.
Yeah. I mean, kudos for the ARCHER trial showing an overall survival advantage. I just think the toxicity it's a big challenge with that drug, having participated in some of the phase 1 experience. Not an easy drug to give, but I'm looking forward to seeing the data presented tomorrow. We've had other data that will be presented tomorrow with erlotinib plus bevacizumab, antiangiogenesis added to the TKI. There's a lot of preclinical rationale why there could be synergy there. Jonathan, you want to walk us through just what we may see with some of these trials with looking at TKI plus an antiangiogenesis?
Well, there are two studies out of Japan that are going to be presented. One is a follow-up of a phase 2 trial that compared erlotinib to erlotinib and bevacizumab, and this time reported overall survival. Previously, it showed a good progression-free survival benefit. Then now it looked at overall survival, and it showed in both groups about 4 years median overall survival, which is very good, but there doesn't seem to be any significant difference between erlotinib and bevacizumab and erlotinib alone, although there was a slight trend towards the erlotinib and bevacizumab. And then, so the phase 3 trial, also conducted in Japan, randomized patients to erlotinib versus erlotinib and bevacizumab, and did show a progression-free survival benefit, 16.9 months median for receiving bevacizumab, and then about 13.3 months median of erlotinib alone, and that was statistically significant. So, you know, it does seem to have some benefit in terms of progression-free survival. Overall survival is still a bit unclear. I think some of the, I think now with osimertinib, I think, that alone, although cross-trial comparisons can be problematic, showed a median overall survival of about 19 months. Also, bevacizumab, you have to come in, get it IV every 3 weeks, whereas otherwise patients can be on an oral TKI. But I think anti-angiogenesis drugs with osimertinib and with next generation TKIs is something that should be explored that may have benefit building upon these these studies. But I myself, with osimertinib first line now, have not used bevacizumab with erlotinib.
Okay. And finally, and I can't remember who we're tossing this one out to, but the lack of IO benefit in EGFR mutant lung cancer patients. There was going to be a trial looking at Pembro in EGFR mutant lung cancer. I'm not sure who wants to tackle this one. Zofia, is that you?
Yeah,
Okay.
so I thought this was a very intriguing and I think a very informative, small but very informative study. This was a phase 2 study out of Eddie Guerin's group. It was a phase 2 study of first-line pembrolizumab for patients with EGFR mutant lung cancers previously untreated. The planned study size here had been 25 patients. They actually only treated 11 patients and stopped the study prematurely due to lack of efficacy. Among those 11 patients who had been, again, TKI naive but treated with first-line pembrolizumab, only one patient had a response. And strikingly, that one patient on further testing actually was found not to have an EGFR mutation. So no responses seen among the true EGFR mutants, which is consistent with the data that we've seen in later lines of therapy. Although I think the hope of this study had been that maybe there would be more activity in a newly diagnosed patient.
Especially those who are PD-L1 high.
Exactly.
Yeah.
So these patients, it's a very good point. These patients were PD-L1 high, in fact, and still we saw no activity. I think what was particularly striking was the toxicities, and in particular, the authors actually followed these patients for toxicities even after the end of pembrolizumab therapy, and they noted 2 deaths within 6 months of pembro treatment, including 1 case of fatal pneumonitis. And I think this really highlights the fact that immunotherapy has toxicities not only during treatment, but even late effects after the end of treatment. There's likely some overlap and some synergy, even potentially between the side effects of immunotherapy and some of the toxicities that we see with EGFR inhibitors. And so I think for newly diagnosed patients, this really hits home the message that testing for EGFR is essential, even in patients who are PD-L1 high. And when patients are EGFR mutant, the right therapy is not immunotherapy for those patients, but rather the EGFR inhibitor. I know sometimes that can be tricky. The PD-L1 usually comes back much faster than the molecular testing. And I've certainly been in the position of saying, oh, great, the PD-L1 is 80%. And I'm all set to go with the immunotherapy. I wait, and then I find the EGFR mutation. But I think for those patients, it really is essential to treat them with the EGFR inhibitor. We don't know about what that interplay will be in larger numbers with the toxicities, and it's really a tragedy when patients die before they're able to get to the TKI.
And I think as you pointed out, with potential toxicity of immunotherapy and TKI, these immunotherapy drugs such as pembrolizumab have a long half-life. So getting pembrolizumab and then getting started on a TKI, there's some potential toxicity that could have been synergistic that led to that pneumonitis. So when I see patients and they, sometimes there's people continue EGFR TKIs through lines of progression, and there's some rationale for that, but particularly with immunotherapy, I would, outside of a clinical trial, I would not, because of that risk of synergistic toxicity. And oftentimes because of the lack of benefit outside of a clinical trial in terms of giving immunotherapy, I usually wait for later lines of therapy and look at other options.
Much later.
Much later. Much later. Although I think now with the EMPOWER study with carbotaxol, bevacizumab, atezolizumab, that's provocative enough that with chemotherapy and bevacizumab may lead to a reevaluation of that, but that was still a subset analysis.
Subset analysis, about 100 patients. I agree. I think single agent IO is probably not a great drug for EGFR mutant lung cancer patients as first, second, third, potentially fourth, and that we need to exhaust TKIs and chemotherapy. So.
And sometimes that could be a discussion with patients, because a lot of patients, even with EGFR mutant lung cancer, want immunotherapy. They want the Jimmy Carter drug.
Yeah.
I mean, people flat out say, because of all the hype surrounding them, which is well founded, but they don't help everyone. And I don't think, especially single agents, they help EGFR lung cancer patients very much, or other ones with oncogenic drivers associated with not smoking. And so, as single agents, I discourage that except for very later lines in therapy, and I often ask them to seek out clinical trials of combination therapies that may have more benefit.